So welcome again, everyone. Just a reminder that this presentation is a part of the COVID-19 and emerging infectious disease track. And today's session is hepatitis C virus evaluation and treatment, role of the primary provider. Our presenters for today's session are Whitney Essex and Dr. Jorge Mera. Whitney Essex has a Master's of Science in Nursing and is a board-certified family nurse practitioner. She has been a nurse practitioner with Cherokee Nation Health Services since 2012. She works in the Infectious Diseases Department, where she is the coordinator for the Cherokee Nation Hepatitis C Elimination Program and co-director of the Ending the HIV Epidemic Program. She assists in the maintenance of a general infectious diseases clinical service, providing primary care for HIV, hepatitis C, and other infectious diseases related patients. She also serves as faculty for several infectious diseases related Project Echo clinics across Indian country. She received her Master of Science in Nursing degree from the University of Alabama at Birmingham in 2011 and is currently pursuing her doctorate degree. Whitney is board certified in family practice by the American Nurses Credentialing Center. Our second presenter, Dr. Jorge Mera, is the Director of Infectious Diseases for Cherokee Nation Health Services, or the CNHS. His work has focused on CNHS response to the COVID-19 pandemic, as well as directing the CNHS HCV elimination program and the CNHS and the HIV epidemic program. Dr. Mera is board certified in infectious diseases by the American Board of Internal Medicine. Please welcome our presenters for today's session, Whitney Essex and Dr. Jorge Mera.
Okay, thank you so much for having us. I'm going to share my screen so we can see our slides. Can you see that? Okay, perfect. So today we're going to be talking about the management of hepatitis C for the primary care provider. Some objectives for our presentation today: we're going to review the epidemiology of hepatitis C in the US. We'll talk about evaluating the HCV patient in a non-specialist care setting, such as primary care. And then Dr. Mera is going to talk about the pharmacologic treatment options for hepatitis C. We're going to start with a case presentation. So here you can see Mr. S. This is his HPI. You have a 24-year-old American Indian Alaska Native male who had a right femur fracture during an auto accident about 6 years ago. He got placed on OxyContin for pain control post-op. And when we designed this case study, we were looking at, actually this is based on a real patient case, right? This is a very typical picture for our hepatitis C patients today. So 2 years ago, he switched medical providers, and this one decided he would not be refilling his OxyContin. So he started getting out the streets and then started injecting it. A year ago, started using heroin. He has to share needles and syringes because the pharmacy won't sell him any. And, this may be a foreign concept to some, but in our location, our pharmacy, they, even over-the-counter needles, they can refuse to sell to patients who they think don't need them for a prescribed reason. 3 days ago, he presented to the emergency department with opioid withdrawal symptoms. And luckily, he ran into an emergency room provider who gave him a 3-day prescription of buprenorphine with naloxone and got him set up with an MAT provider. During the emergency room visit, they also did something that may seem novel for an emergency room visit, but they screened the patient for hepatitis C, which was positive, and his HIV test was negative. Vital signs are normal. Patient sitting in front of you, he looks healthy, except he has track marks in his arm. Otherwise, that's unremarkable. His viral load is positive. We don't have a genotype. He does have some inflammation in his liver. You can tell that by the ALT and AST being a little bit elevated. His platelets are robust at 288,000, and his other labs look unremarkable. He has good renal function, and all of his hepatitis A and B testing comes back as negative or non-reactive. So let's talk a little bit about the dynamics of HCV prevalence. This graph shows shows how patients can go in and out of this hepatitis C chronic infection state. So you have new hep C infections that are going in, and then some patients clear the virus on their own, some need treatment and they get cured, and a portion of those get reinfected, we know, and some patients don't get treatment and they end up dying from complications of hepatitis C. Transmission of hepatitis C occurs mostly by blood transmission, with IV drug use being the leading cause today. There's also some risk associated with snorting drugs, and then you can see the other blood transmission possibilities there. Sexual contact is recorded as a transmission risk for hepatitis C. It is very rare in heterosexual contact, but it is more frequent in patients who are MSM, especially if they're HIV positive. Mother to child transmission is possible as well, and that rate is around 4% of babies who will acquire HCV from their HCV infected mothers. Like I said before, HCV today mostly is caused by injection drug use. More than 80% of all cases are happening in that population. And just as a reminder, when you have the patient in front of you, we always have patients who say that they don't share needles with anyone, and that may be the case, but they also need to know that hepatitis C is really transmissible, and it can live on surfaces that, on hard surfaces for long periods of time. Even the syringe without the needle, the cooker, the table, the tourniquet, the water, any equipment that the patient is touching can be a transmission risk for other people around them who are sharing the same equipment. This map shows the HCV-related death rates compared among states in the US. You'll notice that Oklahoma, Tennessee, Oregon, Washington, all of these states have high rates of HCV-related deaths, and those areas mirror the locations where the AI-AN populations live. This graph shows the rates of acute hepatitis C by age. As you can imagine, acute HCV is largely increased in the younger population, those who are ages 20 to 39. You can see the blue and green lines on this graph. And that's because these are the people who are more likely to have intravenous drug use as a risk factor. From 2004 to 2019, there's been a major increase in the rates of acute hepatitis C in the AI-AN population. The pink line on this graph shows just how disproportionately the AI-AN people are affected, and it's why we are having this meeting today. So let's move on to the evaluation and treatment stage of hepatitis C, keeping our patient case in mind. As a primary care provider, what is my role in HCV, in the care cascade or in HCV management? So first, it comes down to universal screening, and we'll talk a little bit about that more in just a minute, but screening as a PCP, top priority in HCV care. Treatment is also, next best step for a primary care provider. And treatment entails chronic infections to prevent people from developing cirrhosis and related morbidity and mortality, and treating patients who are more actively transmissible. So they're injecting drugs or they have potential risk factors for transmission, their infections. Both categories of patients need to be treated. We'll talk about that a little bit more in a minute. The next job of the primary care provider is what we call HCV surveillance in patients who have cirrhosis. And that's a lifelong surveillance program for patients who have HCV related or any other type of cirrhosis as well. My next biggest job as a PCP is to be an advocate for medication-assisted treatment programs and for syringe service programs, especially if you are lacking those services where you practice. So when we're thinking about screening for HCV, I want you to look at this graph, and here you can see the number of newly reported chronic hepatitis C cases by sex and age in the US for 2018. Males have higher rates than females, but both show this kind of biphasic pattern of new infections. It increases in the younger years, and then you have that dip in the middle, and it increases again in the later years, and that's that baby boomer age group. But in relation to HCV screening, the previous recommendations were for one-time screening among baby boomers, and you can see why. It also included those with risk factors, but the problem with that is that we end up missing the younger group of affected persons who are more likely acutely infected or newly infected. So with, seeing that biphasic pattern of new infections, it prompted the CDC to change the previous recommendation, which was for baby boomer screening. So current CDC recommendations for who should be tested for hepatitis C: every adult at least once in their lifetime, and that's age 18 or above. Every pregnant woman during every pregnancy, and every person who has risk factors regularly. You and I, and as providers or the medical community, we know that risk factors for hepatitis C are not discussed openly frequently. So it's really important, that that patients with risk factors, that they have risk factors, and to know that you usually have to ask. But once you know that, they need to be screened regularly. The purpose of screening is to identify those whose natural course of liver disease we could alter through HCV treatment and cure. This image depicts the natural history of liver disease following initial infection with hepatitis C. You can see that approximately 55 to 85% of persons with a new hep C infection go on to develop chronic infection. 20 to 30% end up developing cirrhosis, and patients who have HCV-related cirrhosis have a hepatocellular carcinoma risk of 1 to 4% per year, and end-stage liver disease 2 to 5% per year. What does HCV treatment accomplish? So check out the stats on the right above that, that nodular-looking liver there. And although treating hepatitis C may not make the nodular liver go back to that nice, healthy liver, but it does help to halt the progression of liver fibrosis that's caused by inflammation from the virus, and you can get some regression of that that inflammation. There's a 70% reduction in liver cancer, 50% reduction in all-cause mortality for people who have been cured of hepatitis C, and a 90% reduction in liver failure. So let's get to the meat of the hepatitis C workflow, which is that workup of the patient. First steps are, so we know screening is the first step. And after screening, we need to confirm the diagnosis. We also have to work up the patient with lab imaging. We're going to stage their liver fibrosis, get any critical information that's specific to the patient we need, and then finally get started on treatment. Confirming the diagnosis is the first step, and screening happens in the form of an antibody test. So to confirm chronic HCV infection or current HCV infection, you have to have a second test, which is the RNA test. This is, people call it a quantification test. It's a PCR test that tells us how many copies of the virus is in 1 ml of blood. And if that test is positive, the person has a current HCV infection. If it's negative, then they either have cleared the virus or they have been treated previously, but either way, they do not have a current HCV infection that needs treatment. So in doing that viral load, once you know that the patient has a quantifiable HCV PCR test, you're going to want to get a genotype, although it is not absolutely necessary. And we'll talk about that. Dr. Mera is going to talk about that a little bit more in the treatment medication stage of this presentation. You're going to want to know if the patient is immune to hepatitis A and if they have ever been exposed to hepatitis B, and if they are immune to hepatitis B by vaccination. So the hepatitis B surface antibody, surface antigen, and core antibody are really important. It's also important to know this is not your standard hepatitis C panel that's built in usually to your EHR. You're going to want to order those 3 specific tests. Testing for HIV because risk factors are similar. Also just your basic CBC, a CMP, and sometimes we do a urine drug screen if needed, but not always. And AFP and PTINR are important if you have a patient who has advanced liver disease. And then you may want to get a fibro test or a FibroSure if your fibrosis stage is unclear. Other tests, just to be complete, if your patient has, especially if your patient has cirrhosis or any other chronic health problems, but an iron profile and a vitamin D test are helpful as well. Staging liver fibrosis seems to be the most, not that I don't want to say it's the most difficult, but we get the most questions about liver fibrosis staging when we're talking to providers about treating hepatitis C. There are 4, or well, technically 5 stages of liver fibrosis, from no fibrosis, which is NF0, all the way to NF4, which is diagnosis of cirrhosis. This can be broken down into compensated and decompensated, and there's 4 things that make someone be decompensated related to their cirrhosis. That's the presence of ascites, esophageal bleeding due to esophageal varices, the presence of hepatic encephalopathy, and jaundice. This slide shows the view of a liver biopsy under a microscope. In the upper left-hand corner, you can see there that you have some, nice, healthy looking liver. And in the one on the right, that's going to be stage 2. There's some mild signs here of some bridging. You can see the blue little lines that show how that fibrous tissue is forming. Stage 3, there's a bridging fibrosis that's very obvious there. And then on stage 4, you have this regenerative nodules. So the fibrosis circles the tissue and causes nodules. The problem, we don't do many liver biopsies anymore. This is still considered the gold standard for staging liver fibrosis, but we have some other methods, and we tend to rely on those other methods as liver biopsy is more invasive. It also can tell you some variation, some variations in your findings with a liver biopsy. If you were to get the core sample in this red dotted box you see here, you're going to get a completely different sample, and with sampling techniques and sampling errors, there's some risk that you may miss someone's fibrosis with a liver biopsy as well. Luckily, we don't do a lot of liver biopsies because we have some other more non-invasive tests that are a pretty good guide for how who really needs a liver biopsy and who you can stage their liver fibrosis just in the office in your primary care clinic. So on the left is a picture of our hepatitis C score calculator. This is an app. It allows you to enter all of the variables you see there, and it outputs a couple of numbers for you. One is the APRI, or the AST to platelet ratio index. Your APRI has a pretty good sensitivity and specificity for predicting cirrhosis when your number is greater than 1. The FIB4 is another calculation that you can see there. It uses the age, takes into account the platelets and the ALT and the AST of the patient. But when it's greater than 3.25, really specific for predicting cirrhosis. And when it's less than 1.45, it has a good predictive value for it being a low level of fibrosis. So those tests are really good. And then we have a FibroTest or FibroSure, which is a blood test. It's a proprietary blood test that can give you a number result for the level of liver fibrosis. Sometimes we move to what's called a FibroScan or transient elastography. But basically this probe, it sends a shear wave through the liver, and it measures the speed at which that wave can pass through the liver. So it can tell you how dense or how nice and soft and non-fibrotic a liver is. This test has some caveats, but it's a really good test, and you have it available. It's useful in hepatitis C. I'll leave this slide for you to review later for reference, but each stage, each METAVIR stage is depicted on the left, and it matches up with your APRI and FIB4, your FibroScan and FibroSure, to help guide you on what stage each number correlates with. So when you're seeing a patient in the clinic, you know they have chronic HCV. If they have obvious signs of cirrhosis, then you really don't need to do any of the liver fibrosis staging tests. If they have ascites already and you know that they have cirrhosis, there's no point in doing these tests. But if they don't have known cirrhosis, then you first would do the APRI and FIB4. If those match, if they're concordant, then you treat the patient based on whatever that liver fibrosis stage was. And if they don't match, if the APRI is high and the FIB4 is low, or if that's reversed, then we get a third test and go with the two that are concordant, and then treat the patient based on that. Why is it important to know the liver fibrosis stage when you're treating a patient? First, it's important to say that, treatment may be different in patients who have cirrhosis who are or are not decompensated. So treatment may vary a little bit based on their fibrosis stage. All patients who have an F3 or F4 need HCC surveillance, and that's done with the ultrasound of the liver and an AFP every 6 months for screening for liver cancer. And all patients who are staged at an F4 also need an EGD to screen for varices, and they need to be monitored for decompensation. And you don't know to do that unless you stage their liver disease. Also, patients with decompensated cirrhosis need to be referred to a liver transplant center for completeness. For this next slide, I'm going to skip over. Dr. Mera is going to go over this in more detail, but he's going to talk about all of the direct acting antivirals that we have to treat hepatitis C. But let's get back to our case. So Mr. S, our main questions are, as a primary care provider, what can I do for this patient? What is his liver fibrosis stage, and how would I treat his hepatitis C? So first, let's plug in his numbers. We've put them into the HCV score calculator. We get a APRI of 0.58 and a FIB4 of 0.64. Both of these are very low scores. We'll look at where that puts him for a fibrosis level, but it's going to be low. We're going to vaccinate him for hepatitis A and B because all of his testing was negative for hep A and B. Keep him on the buprenorphine naloxone, and also going to give him safe injection education, talking about harm reduction with the patient. Be an advocate for syringe service programs in your area, and then look at our treatment options. And let's go to that slide. So treatment options are best discussed with our Project Echo. Have to put a plug in for Project Echo, but presenting patients to a panel for some guidance, and to an expert panel for guidance on treatment and evaluation of hepatitis C patients is always a great idea when you're first starting out treating hepatitis C. And this is what we would go through during that presentation. So your patient has an RNA. We've gotten their low fibrosis staging. The platelets were more than 160, and the FIB4 was less than 1.45. So the patient does not have cirrhosis. This is a patient I would definitely feel comfortable treating in primary care and would go to Epclusa for 12 weeks or Mavorette times 8 weeks. If the patient that we had today had a FIB4 over 1.45, this is a patient that you would want some more guidance on and would definitely want to present the patient in an echo meeting to an ID specialist or other hepatitis C experienced provider. So I just wanted to to show our roles as PCPs in hep C management again, and just remember that you can play a big part in decreasing the morbidity and mortality associated with hepatitis C. We can help with transmission by having our MAT waiver, prescribing Suboxone or other medication-assisted treatment options, advocating for syringe services, and committing to this process to treat patients. It is a lot of work to treat hepatitis C in the beginning, but it is definitely one of the most rewarding things that you could ever do as a primary care provider. And I have some resources there, and we'll go to Dr. Mera's part of the presentation.
Thank you, Whitney. Okay, I'll have you move my slides for me, please. So next slide. So, Whitney covered already all the epidemiology and management and evaluation of the patient. So I'll just focus on the last 15 minutes on what I think the primary care providers should manage for treatment of hepatitis C. And I'll divide this in 3 small sections: benefits and contraindications of DAAs or direct antiviral agents, and what options of DAAs do you have on a practical basis, and what makes you choose one DAA over the other when you're treating a patient. Next slide, please. So Whitney already covered this, but it is important to understand that there are substantial benefits of curing hepatitis C. And technically, we call this achieving an SVR, or sustained virological response, which means that 12 weeks after you finish treatment, you check a viral load and it's non-detectable. And you can consider that patient cured for life, unless he gets reinfected if he engages in high-risk behavior. So you can decrease the risk of liver cancer, all-cause mortality, liver failure, but also you can improve if the patient has any extra hepatic manifestations like diabetes or kidney problems, you can improve them, and definitely you can prevent them from occurring once you have cleared the viral RNA, I'm sorry. So who should not be treated? So, in our minds, everybody should be treated, but there's 1 or 2 things you need to remember so you don't make a mistake. So for now, pregnant females, you should not be treating them because it's not FDA approved for this situation in their lives, but you can definitely treat them after they have delivered. And I will not be surprised if very soon we will have some FDA approved treatments in pregnancy. Children, the age has come down with the direct antiviral agents, and now we can treat children 3 years or older, but not younger than 3 years yet. Patients in which have a life expectancy of less than 1 year, but not related to liver disease. For example, you can see a patient with decompensated cirrhosis that you would calculate that he has only a year to live, but if he gets or she gets a liver transplant, they can have a very long life. So any life expectancy that's shortened to 1 year, not related to liver disease. And then patients taking certain concomitant medications that we will discuss briefly. Next, please. So next, DAA treatment options. Next, click one more click. Go ahead and click so you can show the whole thing, Whitney. Thank you. So on this graph, slide, you can see the 3 areas in which the direct-acting antiviral agents inhibit the virus, and some do it at the protease level, some use a non-enzyme target, and then the other ones inhibit the polymerase. And here I listed all the drugs that act on each of these 3 sites, and I highlighted in yellow the ones that are still in the market because the majority are not being used anymore. And it seems complicated when you look at it here. You see a lot of drugs with weird names, difficult to pronounce, or at least for me. But now we'll see it is not that complicated. Can you go to the next one, Whitney, please? Okay, this graph is just to show that all these on the left are the medications that are still available on the market, and then the genotypes that they inhibit. And only Epclusa, which the pharmacological drugs are on the top right for you to look, Vosevi and Mavorite are pangenotypic. The other 2, you can still use them in certain genotypes, like genotype 1 and sometimes 4, but lately, even the third-party payers are not covering them for commercial reasons. But there's still options if you need them. But the practical thing is that you'll only be using 2 medications for 95% of your patients, which is Epclusa or Mavorite. Next slide, please. So Epclusa, which is velpatasvir, sofosbuvir, it's pangenotypic. It'll cover any genotype. It's approved for pediatrics if their children are 3 years or older. It's 1 tablet once a day, with or without food. And that's important because some patients may have problems finding food, especially if they're homeless, or may have difficulties taking certain foods with the medication. So if food is an issue, this is a better option. Very little drug-drug interactions, but one definite drug interaction that we'll cover a little bit more is with antacid medications. There are some rules that you need to know. Another very important thing, you can use it in patients that have renal dysfunction, including dialysis. And more important, because actually Mavorite you can also use in dialysis, but you can use this drug in patients with decompensated cirrhosis. And you will see that the next drug you cannot. So those are important things to know about this medication. Next. Regarding antacids and NS5A inhibitors, here I place two, sofosbuvir ledipasvir, which is Harvoni, or sofosbuvir velpatasvir, which is Epclusa. For the Epclusa, the one that you're probably going to be using more frequently, it's best not to take any antacids, but if the patient needs to, they can use omeprazole, less than 20 milligrams or less, and take with food 4 hours before they take the omeprazole. But we try to consider discontinuation of acid suppression, first because it's not indicated in 80 or 90% of the patients that are using it. But let's say it is indicated, you can, if the patient's taking 40 milligrams and you really want to use Epclusa for whatever reason, then you may try to get the patient to taper him off that 40 milligram dose and go down to a 20 milligram dose, or even switch him to famotidine if it works for the patient. Now taper the medication slowly, because one thing that you don't want is to take it off completely 2 days before they start the Epclusa, and then they have severe GERD when they're taking the medication and you have problems then continuing the antiviral. And there are some rules for the H2 blockers. You take them 12 hours apart concurrently, and do not use more than 40 milligrams of famotidine. Other antacids, as long as you spread them out for 4 hours, it's fine. Next slide, please. The Mavorite is also pangenotypic. It's glecaprevir and pibrentasvir. You can also use it in children at least 3 years or older, and there's no problems with renal dysfunction. But this one, because it has a protease inhibitor, you cannot use in patients with advanced liver disease, meaning Child-Pugh B or C class. So our personal preference is to not try to use it in patients with cirrhosis unless we cannot use the other medication, Epclusa, for some other reason. Next slide, please. So other drug-drug interactions that are important. When you're going to use the protease inhibitors, meaning Mavorite, you need to make sure that the patient's not taking a phenylestradiol containing products, because that could affect their liver function tests. So you want them to use a different birth control method, such as progesterone. Omeprazole can be used with Mavorite, but you cannot use more than 40 milligrams in 1 day, and you have to give it 1 hour before the Mavorite. And this is not because 80 milligrams will be a problem, it's because 80 milligrams was not studied. And so we have good data on up to 40 milligram dose. And there's no interactions with H2 blockers with Mavorite. So if you have a patient that has severe GERD, this is usually our drug to go to, unless the patient has decompensated cirrhosis or advanced liver disease. Next slide. These drugs are very well tolerated. Symptoms that sometimes patients mention is headache or fatigue, and sometimes some GI symptoms. But the reality is that most patients tell you they feel much better since taking this medication, or they can't even tell they're taking it because it's really very low side effect profile. Next slide, please. So I already covered many of these points, and I'll just stress a few of them. Statins are a problem with these drugs, and I'll show you on the next slide what you have to do if a patient's taking a statin. Digoxin could be a potential issue, but the reality is that the majority of patients are not using digoxin today, so it's not something that you run into frequently. We do run into frequently sometimes people who have seizures and are taking anticonvulsants like carbamazepine or phenobarbital or phenytoin. And these drugs, when I see them, it should raise a red flag. You cannot use them with any of the hepatitis C antiviral medications. So you need to talk to the neurologist or the primary care doctor or yourself if you're the PCP and try to switch the patient to another anti-seizure medication while they're on hepatitis C treatment. We did mention about the ethanyl estradiol. We did mention that you cannot use protease inhibitors like Mavorite with patients with advanced liver disease. We did touch already the antacid interactions. And finally, also, this is rare, but it was reported. Patients who are on amiodarone should not be using sofosbuvir containing products because there's some reports of severe bradycardia, and this would be the Epclusa that you could not use. Next. So I just simplified the table to Mavorite and Epclusa. The other antivirals also have problems, but these are the ones you're going to be using more frequently. And Mavorite is a bigger problem than Epclusa. You can only use rosuvastatin at a 10 milligram maximum dose per day when you are using Mavorite, or pravastatin. The other ones are contraindicated. And with Epclusa, you will have either no interaction with some of them or some degree of interaction that you need to either decrease the dose or monitor the patient. What we usually do in real life is if the patient does not have a hard indication for the statin, we have them stop the statin while we're treating their hepatitis C. But if they have the statin because they had a heart attack or a stroke or some important event, then we prefer just to use the dose that is allowed that you're seeing in these tables. Next slide. So finally, variables that influence treatment of choice. The genotype, except for one situation, if you have a genotype 3 with cirrhosis, you need to know that because you'll need to do resistance testing if you're going to use Epclusa. But if you're going to use Mavorite, you don't even need to know what the genotype of the virus is to treat that patient. Viral load, only if you're using Harvoni. There's some rules depending on the viral load. You need to, you can use Harvoni for 8 weeks instead of 12 weeks, but it's not a drug that we're using anymore. Fibrosis stage, well, as Whitney mentioned, you have to stage the patient. If they have advanced liver fibrosis, especially decompensated cirrhosis, you will not want to use Mavorite or protease or any drug with protease inhibitors like Zepatier. Drug-drug interactions, sometimes we choose a medication because the patient is on high dose of omeprazole and we can't get them out of it. So then we incline for Mavorite. Or they're using ethanyl estradiol as contraception and they don't want to change, and maybe we don't want to change them either. So we'll use Epclusa. So those are the things that guide us of one drug or the other. Then it's patient preference. Do you want to take 3 pills once a day, which would be Mavorite, with food? Or is that a problem and you just prefer to take 1 pill a day with or without food? So that also gives us some guidance on what to use. And finally, which is very important, is what medications do you have available? Many patients in certain states, they have Medicaid, and Medicaid has different preferences. So it also influences as if you can get one medication really quick and not have to wait weeks or go through appeals to get a second one because the insurance or the third-party payer is having a preference. So these are all the things that influence your choice. Next. So this is just one of the echo algorithms that we use. So next, let's say this is a genotype 2 patient. Next. The first question, do they have cirrhosis? And if the answer is no, then we go to, is the patient experienced with other antiviral therapy before? And if the answer is no, then there's 2 options, either sofosbuvir or paltusvir, or Mavorite is for 8 weeks. And then the decision will be about other things like patient preference, insurance preference, things that we covered on the previous slide. Next slide. So always perform drug-drug interactions. We always work with our pharmacists and our lives are blessed. But if you don't have a pharmacist, there's 2 references. The one that I use is University of Liverpool Hep C Drug Interactions. It's a free app. It's really good and it tells you exactly what you need to do in case the patient's having other medications that could cause a problem. And I think that is it. Yes, and thank you. And we're open for questions.
Thank you so much for that wonderful presentation. It was very important. It was very informative, and I learned a great deal about the epidemiology and clinical treatment of HCV. We can now transition into the Q&A portion of the session and take any questions that participants might have at this time. Please feel free to make comments or ask questions in the chat box for our presenters, or you can simply unmute yourself since we are a small group today.
I just had a comment. This is the best, short presentation for hepatitis C that I have seen, and I've seen a bunch. Really, really great information, very well condensed and practical. So I'm glad that the session's recorded because people will be able to watch it at a later date. So that's great. And thanks very much to both Dr. Mera and to Whitney for such an outstanding presentation.
Thank you, Harry. Appreciate the comments.
I'll ask a question. What are some common challenges that you have faced in your work?
So I'll start with that. So I think, with hepatitis C care in particular, the most challenging thing is the social aspects of the patient's care. Treating and curing the hepatitis C, and we tell patients this during their visit, that's going to be the easiest part of taking care of them for me as a provider, is writing a prescription for their hepatitis C treatment. Deciding what to do for their hepatitis C treatment is easy. But when you add in the fact that you can't prescribe them Mavorette because they don't have a safe place to keep it, because it comes in a box and the box is like this big, and maybe at the shelter they're staying at, they only have a locker that's this big to keep all of their belongings in, and that's it. So you have other things that come up along the way that really are those social, it's the social determinants of health that are barriers for anyone's healthcare, no matter what their problems may be. But these are, it's like they're magnified in hepatitis C care because of, usually the lifestyles that they're living, or the choices that they are making are, they make it difficult sometimes to get their hepatitis C treated and cured.
Thank you for that response.
Yeah, sort of as a follow-up to that question, what I see here, in North Carolina with the Eastern Band treating hepatitis C, it seems like we lose a fair number of people, partway through the treatment course. We lose them to follow-up. So, and I think it's exactly what you just said, Whitney. It's the social aspect of things. Do you have a statistic on the number of people who failed a complete treatment? I think you did. I think you showed that Monday with your hepatitis C elimination program presentation. Seems like it was about 25%. Is that right?
Yes. So on the cascade of care, there's, each column has a gap. Interestingly, the gaps are always 24, 25%, depending on the state. So it doesn't seem a lot, but when you add 3 of them, you have a lot of people, dropping off. So yeah, it's about that. Now that 24% includes all causes. And sometimes, I think I agree with Whitney, the majority are these social issues. But I think that we have not been aggressive enough to try to tackle those problems. And not because we don't want to or because we don't recognize them, it's because we don't get the support to do that. And for example, in the ideal world, it would be to ask the patient, what do you think could be barriers in you completing treatment? And have a very frontal, very sincere conversation. actually after you give them the bottle, so they're not afraid that you're not going to give them the bottle if you of medication. And then if they say, it's my drug use, or I don't have money to get to the clinic, or then you could maybe help them be successful in that problem they're having. But I think there's still a gap between what the services we provide and the needs of the patients. And we need to work hard on covering that gap, or else we're not going to be able to eliminate this disease.
To address the question in the chat, yes, the slides will be available, I believe, for up to 3 months using the links provided for the Zoom session, as well as in the agenda and calendar invites. I had one last question. What does HIV, HCV co-infection treatment look like? Is it drastically different from what you guys outlined, or what does that generally look like?
That's a great question. So it's not very different. I mean, we can still use, depending on the HIV medications that the patient is using. There are some drug-drug interactions, but in general, you can use Epclusa and you can use Mavorite. You just have to do a drug-drug interaction checker with the antiviral for HIV that the patient is using, and see if there's any interaction that you need to avoid. The most important thing sometimes, or the question is, when do you start? You start both treatments at the same time. Sometimes, like the other day, we had a patient that had HIV and hepatitis C, recently diagnosed. So, and there's a lot of different opinions in the literature. What we do is we try to tackle the HIV first. Because let's say the patient's injecting drugs, we want to cut transmission of the infection he has as soon as we can. If he transmits HIV, that's a non-curable disease. Even if he transmits hepatitis C, that still is curable in the other fellow that got the infection. So we can still have a chance of curing them. And the reason we don't start both at the same time is because if there is a side effect, we won't know what's causing it. And we want to make sure that they are, taking at least the HIV medication, which is usually 1 pill. And after a month or 2, if they're tolerating it, they're taking it correctly, then we jump and do the hepatitis C treatment. Also, there's some evidence that with a better immune status, there's a better response to hepatitis C treatment. Although the responses are great no matter what, they're above 90, 95%, but some authors recommend that. I don't know why we don't have a lot of co-infections. We don't see a lot of HIV, Hep C co-infections. And I think it's just, we've been lucky, because they can be transmitted through the same process of injection drug use. So, but it is puzzling to me why we don't have more co-infections, especially more HIV, which I'm glad we don't, by the way, but
yeah, it's the same here. We almost never see HIV, and that's not how it is in much of the country. You often see the two together, and I've had other people question, and I don't have any answer for that. I don't know if you have any speculation. I mean, the only answer I have is, yeah, we've been lucky. I'm afraid that if it ever does get into the population, we're going to see an explosion of HIV.
Right, I agree. Like happened in the Indiana story, in Austin, Indiana, they had that big outbreak in 2015 in a little town of 5,000 people. Suddenly, in a matter of months, they had over 150 patients with acute HIV, and 80% Hep C infected. So it's I think we've been lucky. And that's why, like Whitney mentioned, Hep C is the tip of the iceberg, and we need to take a deeper dive on addressing substance use disorder, having clean syringes and needles available to the patients, which I know we have a great program in the Eastern Band with that. And hopefully we will soon also in Oklahoma, because that has been recently legalized. But you need to be very holistic and tackle all the problem and not just, one little part of it, which is hepatitis C. You will hear Whitney say on our echo sessions, oh, the easiest part is the hep C. The easiest part to treat is the hepatitis C, and that's true. That's the easiest part. The other components are more challenging and complicated.
Thank you for sharing, and that is very interesting to find. So thank you, Whitney and Dr. Mera, for this great session and appreciation of your support of USET and dedication to tribal public health. We will be shipping you both a small gift at the close of the conference, so please be on the lookout for that. Additionally, all attendees' names will be entered into a daily prize raffle once for every breakout or plenary session you attend. So winners for that will be announced in tomorrow's plenary. I'm going to now share a graphic on the screen to show you the daily raffle prizes that you do have the potential to win. I'm not sure if everyone's able to see this, but we have 5 Porch Banded Creek Indians beaded lanyards, 10 USET Indigenous Truth t-shirts, and 15 8th generation gift cards that you have the potential to win.
Can the speakers participate in the raffle or only the audience? It's a joke, don't worry.
I think it's just the audience, but we will be sending you both a small gift as well. Before we close, I will also be launching a poll that should pop up on your screen in just a few moments here. If you could just take some time to answer the question that pops up. And so please complete this anonymous poll to help us evaluate this session. Also, don't forget to visit the exhibit hall and lounge area if you've not already done so. One last reminder before I put up the poll, please remember before you exit the conference today that we do have a film festival that can be accessed through the Vision Maker Media exhibit booth. So please feel free to check that out as well. I'll just take a few moments to answer the question. Alrighty. And I just want to thank everyone again for attending today's session. We look forward to seeing everyone tomorrow morning, and I hope that you have a wonderful day.
Thank you so much.
There's one question.
I know, I just now, Stephen. I don't know if you guys would mind answering this one last question or not, but are
Sure.
there any contradictions with HCV treatment and individuals on PrEP?
No, there's no contraindications, but depending on, so PrEP uses tenofovir as part of the treatment component, and sofosbuvir-based regimens like Epclusa may increase the levels of the tenofovir. So the recommendation is just to monitor the patient's renal function during treatment. But if you were using Mera, there wouldn't be any major issues. And we use Epclusa when we're having Truvada and Epclusa together, and we just monitor the renal function. But that's a great question because many of these patients require all of these things. All right, thank you. Bye-bye.
Thanks. Bye-bye.